Hey, good afternoon, everybody. My name is Sadaf. I'm a consultant neonatologist at UCLH in Great Ormond Street and part of the NeoFOCUS education team. So welcome to this NeoFOCUS webinar on the SLURP study, which is serial lung ultrasound in predicting the need for surfactant and respiratory course in preterm infants, which is a multi-centered observational study. Before introducing the speakers, I'm just going to go over some ground rules. So in terms of questions, the questions will be taken at the end. So in the last 10-15 minutes, please post them in the Q&A box and they'll be answered in due time. If you do want to speak or discuss something, please do raise your hand. We try and discourage it, but if there is a real need to, then we can try and facilitate you talking if time allows. You'll also receive an email tomorrow with a link to a feedback form, and once that's completed, you'll get a link to download a certificate, which you can self-complete with your name. We're really lucky today to have the CA of the study, who is Dr. Prakash Loganathan, and the co-investigators of the study, Dr. Virginie Maupetit and Dr. Bikash Bojnagarwala. So Dr. Loganathan is a consultant neonatologist at James Cook University, interested in research and academics. Virginie is a senior neonatologist and key advocate of neonatal lung, but also heart, lung, and abdominal ultrasound in the UK since 2014, and is a co-founder of the NeoFOCUS-UK education group. And Dr. Bikash Bojnagarwala is a consultant neonatologist at Medway with a focus on neonatal and pediatric cardiology and certified in congenital heart disease echocardiography. He has expertise in point of care ultrasound for lungs, lines, and heart assessment and integrated hemodynamics and structural congenital heart disease. I'm going to hand over to Prakash. The floor is yours.
Good afternoon, everybody. My name is Prakash Loganathan, one of the neonatal consultants at James Cook Hospital, Middlesbrough. So today we're going to present our recently completed study, serial lung ultrasound in predicting the need for surfactant and a respiratory course in preterm infants. It's an observational study. This study was possible with the collaborative work for all my co-investigators who are active members of NeoFOCUS, Mohammad Montasser, Virginie, and Bikash. The study is funded by KC. Background. So we all know yearly use of CPAP and selective yearly use of surfactant in preterm infants with respiratory distress syndrome is recommended. The current practice is to give surfactant to these babies who are on non-invasive respiratory support when they reach certain threshold, commonly the oxygen threshold, anywhere between 30 to 40%. This FAO2 threshold is used without any strong evidence. Sometimes some babies could take longer time to reach the threshold. By the time, the surfactant administration could be delayed and the actual full benefit of surfactant is not going to the baby. Few studies have shown that yearly lung ultrasound could predict the need for surfactant in preterm population. Moreover, lung ultrasound could be performed easily at the bedside at point of care and requires very short period of time, around 3 minutes median time, non-invasive, no radiation hazard, has a steep learning curve. It has a very good inter-rater reliability. Our research question was, it's nothing groundbreaking, simple question. Preterm infants who are less than equal to 34 weeks on non-invasive respiratory support, can we perform yearly lung ultrasound before surfactant administration, that is within the first 3 years of life, performed by operators of varying level of expertise compared to chest X-ray, other clinical criteria such as oxygen and the pressure used, which can predict the need for surfactant. It's a multi-center, that is 3 hospitals. One is James Cook Hospital, Wishaw at Scotland, and Kent Medway. Prospective observational longitudinal study. Our primary objective is to assess the diagnostic validity of lung ultrasound performed by operators of varying levels of experience and what is the best score using 10 versus 6 zones, that is the front and the back, within first 3 years of life to predict the need for surfactant in preterm infants who are less than equal to 34 weeks and on non-invasive respiratory support. The secondary objectives of the study were to study the value of serial lung ultrasound until day 3 of life and to predict the need for second dose or repeated dose of surfactant, to predict the development of BPD at 36 weeks, and report the correlation between chest X-ray, we used Perils classification, and lung ultrasound, and the correlation between Silverman-Anderson score, which is commonly used clinical score for respiratory distress assessment and lung ultrasound. Our inclusion criteria: babies are born with birth gestational age less than equal to 34 weeks based on last menstrual period or ultrasound dating and needs to receiving non-invasive respiratory support or low flow oxygen and needing neonatal unit admission. We excluded babies who received surfactant before the first lung ultrasound. Babies who had major congenital malformation as determined by the medical team. Infants who received delivery room surfactant or intubation immediately after the admission, where there's no time to perform lung ultrasound, we would exclude those babies. Infants diagnosed with pneumothorax who needs any intervention like needling or chest tube drainage will be excluded from the study. We assessed 5 lung zones in each side, total 10 lung zones, and we used 30-point scoring system, and each of the scores vary from 0 to 3 in each zone. The 5 lung zones are upper anterior at the midclavicular line and lower anterior, and then lateral, upper posterior and lower posterior. We used lung ultrasound scores adapted from Pratt et al. Score of 0, which is only horizontal or A lines only. Score 1, which is well spaced vertical B lines. Score of 2, were coalescent crowded B lines. And score of 3 with extensive consolidation. Before we started the study, we conducted full day workshops independently at each of the centers, and also we developed an online learning module. And all the scans in this whole study performed by local team members. We divided the operators into 4 groups based on the experience levels. People grouped as training only if they completed only online course and workshop. Beginner who have performed at least 20 scans with 5 to 10 supervised scans. Intermediate group 50 to lung ultrasound scans of all pathologies. Advanced more than 70 lung ultrasound scans of all pathologies. This is a study algorithm. A baby who was born at equal to or less than 34 weeks and on non-invasive respiratory support, we would perform the first lung ultrasound within 3 years of life. If they continue to be on non-invasive respiratory support or receive surfactant by any other method, by endotracheal, LISA, insure or ventilation, still both group of babies will get second lung ultrasound 12 to 24 hours after the first lung ultrasound. Subsequently, they get the third and fourth lung ultrasound every 12 to 24 hours. We performed 4 lung ultrasound in the first 3 days of life. That is our first study endpoint. All these infants were followed up to hospital discharge to collect details on hospital outcome. That is our final study endpoint. We collected clinical, demographic, and hospital outcome data from Badger and some case notes. We had paper printed workbooks where real time when the operators perform the lung ultrasound, they complete the data collection form based on for the lung ultrasound. The current standard for diagnose RDS is X-rays. The sensitivity of chest X-ray in predicting the need for surfactant is around 38%. In order to improve this to 60% per lung ultrasound, we will need approximately 39 babies to show this difference with the power of 90% and the alpha error of 5%. With expected data loss, we aim to recruit at least 50 infants. We wanted to recruit out of 50 infants, at least half of them should be smaller gestation, that is less than equal to 29 weeks. So we thought we'll recruit until we reach these numbers. We applied for ethics and research approval, which was obtained last year, 2023. We got approval for retrospective consent because our study did not have any change in the current practice. We did not perform any intervention based on lung ultrasound because the lung ultrasound images recorded by the operators are blinded to the clinical team. That means we perform the lung ultrasound, we will not tell what is the score, we'll just keep the lung ultrasound. So there's no clinical change happened because of lung ultrasound. We did not collect any identifiable information or we did not publish any identifiable information. So we got approval for retrospective consent for using the data and the images. So we recruited a total of 83 infants, preterm infants less than 34 weeks over a period of 1 year, May 2023 we started to June 2024. Among the 83 infants, 34%, 28 babies received surfactant, 19 by Lisa method and 9 by intubation. Two common reasons why we could not recruit infants were proportion of the babies received intubation in the delivery room and proportion of babies we could not perform because of the non-availability of the trained personnel to perform lung ultrasound. This is a study flowchart, recruitment flowchart. As you could see, each centers, how many were screened, how many are eligible, and the reasons for why we could not recruit each centers, and how many were recruited, how many final numbers are available for the analysis. As you could see, we recruited 38 infants from James Cook, 11 infants from Wishaw Hospital, 37 infants from Kent Medway. So final number available for analysis was 83. This is our demographic respiratory support data. So we had around 53 babies who are male. The median birth weight was 1,500 grams and median birth gestational age in weeks was 31 weeks. 77% of the infants were born by cesarean section. The admission temperatures predominantly they were normal. The clinical risk index for babies to score, CRIP score, was 3, which is very low. 91% of the babies received some steroids and 18% of the mothers were diagnosed with diabetes. Among our study, 23% of the population had multiple pregnancies. The numbers in the bracket were interquartile range. This is a second table which showed the timing of lung ultrasound, the respiratory support, and who performed the lung ultrasound. The first lung ultrasound, we had 83 scans were performed, 83 lung ultrasounds were performed with a median time of 1.93 hours. The second lung ultrasound, we had 89 ultrasounds were performed with median time of 20.3 hours. Third lung ultrasound, we had 81 scans performed with 40.4 hours of the median time. The fourth lung ultrasound, 80 lung ultrasounds with median time of 61 hours. As you could notice, majority of the lung ultrasound performed by training people in the beginner only. And in most of the babies were in the supine position. To start with, before the first lung ultrasound, majority of the baby were on CPAP, and we reported the median SpO2 FiO2 ratio and the median oxygenation index and the Anderson-Silverman score and the chest X-ray score. There were 27 clinical members of staff performed the lung ultrasound. Out of that, 16 were trainees, 2 were nurse practitioners, and there are 9 consultants. We had a total of 325 lung ultrasounds. Out of 325, 11%, 37 lung ultrasounds were uninterpretable. 14% of the scans were performed by the operators in the training group and 17% of the beginner operators. Just again, one more point to add, all the lung ultrasounds performed by the operators of the local team and all the lung ultrasound video clips were transferred without any identifiable information, without any clinical data to the expert investigator, that is Virginie. So she have access to all the videos, but she doesn't have any access to the clinical information. All the scores, all the analysis were performed based on Virginie's score. So this flowchart shows how many videos we performed in each center for each of the scans and how many were uninterpretable and how many available in the total. So as you could see, there are a total of approximately around 3,000 lung ultrasound video clips, and how many were uninterpretable is for each center has been shown in this flowchart. This is a main results table. So let us focus on the first lung ultrasound, which is performed within 3 hours for surfactant need. So we reported separately into 10 zones. That means we perform the lung ultrasound on all the 10 zones, that is front or back, and then 6 zones only. So again, to add one more point, the 10 zone, 6 zone depends on if the baby is lying on supine, that means we performed the anterior side. We requested the nursing staff to tilt. We are not asking the position to change completely, tilt to the back so that we can access the back of the baby and perform the lung ultrasound. If the baby is clinically deemed to be unstable and the clinical team is not happy, we did not perform the other part of it, the back part of it. If the baby is already on prone position, we performed the back posterior part. Then we requested the nursing staff to tilt to the anterior side. We access the anterior side accordingly. The 10 zones includes both anterior and posterior, 6 zones based on what was the default position of the baby. If the baby is lying down supine, that means anterior and the lateral forms are 6 zones. We calculated the sensitivity specificity for each of the score, but we reported mainly the scores for 8 and 9 because as this score is commonly reported to have a better diagnostic value for predicting the surfactant need. All you can notice for the score of more than equal to 9, that gives the best sensitivity and specificity of 79% of sensitivity and 75% specificity. The score of 9, what was our cutoff in this lung surfactant prediction. Next, we'll go to the chronic lung disease BPD prediction. The first lung ultrasound, 10 zones, 6 zones. Again, score of 9 equal to more than 9 had the better results, the best results of the sensitivity of 73% and specificity of 76.3%. The fourth lung ultrasound for chronic lung disease or BPD did not give much value actually. If you see the score 10 zones, 6 zones, it's very low value compared to the first lung ultrasound for predicting chronic lung disease. In all of the situation, adding extra zones, 10 zones, increases sensitivity but marginally increases specificity. So one of the conclusion or one of the impression we had was that there's no need for turning the position of the baby. You can get meaningful diagnosis just by performing lung ultrasound on the default position of the baby. So this is the same results by presenting the ROC curve. So we are focusing first on the graph on the my right hand side, the where I can put the pointer, the lung ultrasound score surfactant. The blue line indicates 6 zones and the red line indicates the 10 zones. As you could see, the area under the curve is not much different between 6 zones and 10 zones of 0.8, which is considered as a good area under the curve, good diagnostic value. Similarly, if you go to the chronic lung disease, BPD, the 6 zones and 10 zones, for the first lung ultrasound, the area under the curve is again 0.80. There's not much difference between 6 zones and 10 zones for the first lung ultrasound. So we showed statistically there's no significant difference between 6 zones and 10 zones. We get similar diagnostic value by using 6 or 10 zones. So this area under the curve for a specific subgroup where we wanted to look at the smaller population who are less than equal to 29 weeks. As you could see, we had 29 babies who are less than 29 weeks or equal to 29 weeks. The area under the curve is slightly better for them. They are able to predict the need for surfactant better. The 10 zones is 0.94 and 6 zones 0.92. Again, chronic lung disease. Again, the first lung ultrasound performed slightly better than the fourth lung ultrasound. Again, 6 zones and 10 zones, kind of similar area under the curve. So again, this was a surprise finding for us. The first lung ultrasound had a better diagnostic value even for BPD. This could play a role in early identification of high-risk babies. For example, if you want to give hydrocortisone, can I use a risk strategy with the high lung ultrasound scores? Can I use these babies to give hydrocortisone? That was a clinical implication of this finding. So again, we reported here each of the lung ultrasound, 6 zones, 10 zones for the BPD diagnosis. As you could see, the first lung ultrasound has the best area under the curve for 6 zones and 10 zones. And second, third, fourth, the area under the curve is nothing greater than the first lung ultrasound score. Correlation. The correlation between first lung ultrasound chest X-ray score was around 0.53 and for 6 zones 0.51. It's not the greatest, but better than Silverman and Anderson score, which is around 0.32. As you guys know, Silverman Anderson score is quite subjective. Chest X-ray score is also a bit subjective, but slightly more than objective than Silverman and Anderson score. When compared between the SpO2 and FiO2 ratio, the correlation is much better. That is negative correlation. That means what's the lung score, what's the ratio of rho of 0.62 minus 0.62. Again, oxygen index has again a better correlation of 0.60 when compared to 10 zones and 6 zones. So we compared our inter-rater agreement between the expert score and the local operators. So as you could see, the CAPA agreement, the general agreement is pretty good, around 70 to 80 percentage. The CAPA agreement varies between, for 10 zones, 6 zones, areas between 0.45 to maximum of 0.65, which is considered as moderate to substantial. Our agreement rate between the operators and the experienced person is slightly lower than reported in the literature because, as I showed you before, majority of the lung ultrasound is performed by people who had only training only or in the beginner phase. Hence the variation in the results. So in conclusion, our study has shown that lung ultrasound enables clinicians to offer yearly targeted surfactant therapy, which is a need for in this era of precision medicine. The potential use of lung ultrasound to predict BPD very early on. Our research with a structured training program enabled novice operators to perform lung ultrasound and they can achieve reasonable competency. How could this study affect your practice? Lung ultrasound is relatively easy to train with structured training, which will allow clinicians to provide yearly targeted therapy for surfactant and able to predict BPD early on and potential also to reduce the number of X-rays. And also, as I mentioned, there's no extra value, added value of changing the position of the baby. So that you could have the similar diagnostic value by performing lung ultrasound on the baby's default position. That should give a good diagnostic answer for that particular baby. Thank you.
Thank you very much, Prakash. Bikash, I'll hand over to you.
Thank you so much, Prakash, for the wonderful talk. And thank you so much, Sada, for introducing us. So I can see few questions online. So I would, as Sada was mentioned earlier, if you guys can pose your questions online, we'll have a look. So the first question I can see is from Ashraf. Uh, who's mentioned I use Brett scores of 8 to give surfactant in RDS for first dose and score of 10 for the repeat the dose and the score of 6 at 14 days to predict BPD. What do you think about that?
Yeah, so that's Ashraf, what you're using is what is currently in the literature. Ours was not study. We just reported what is the best score that gives value for diagnosis. We found a score of 9 for surfactant first dose. Unfortunately, for second dose of surfactant, we had only 2 babies received 2 doses of surfactant, so we could not perform any analysis. Even the recent meta-analysis published in 2024, they could not perform any meta-analysis on the second doses, subsequent doses, because there's so much heterogeneity uh, of when to use second dose surfactant. In my personal opinion, for the repeat course, second dose surfactant, still what the best score, it's a bit unclear. So again, the question about the BPD, again, a lot of studies have shown that later on scans like day 7, day 10, day 14, the chance of predicting BPD is much higher. So we agree, but we didn't perform after 3 days, so we don't know how to comment on that. But again, my another counter argument point as a neonatologist, after 2 weeks, if the diagnosed BPD, predict BPD, is there going to be much use because you want to predict and prevent, do intervention the first few days of life before the inflammation starts. So we need a tool which can be predicting much early on so that it can act and risk-based intervention can be done. Hope that answers your question to some extent, Ashraf.
Mm. No, thank you, Prakash. That validates your point very well because now the whole idea is, and all we are trying to do is identify all these high risk patients earlier. So it is really a good. I don't know of any study which has ever used lung ultrasound scores to integrate the prediction for risk of BPDs in babies. So we use this NISD calculator to predict the risk of BPD, and then we stratify them to hydrocortisone or even giving a moderate dose of steroid. So I don't think so any study is ever used. So that opens a whole new area. Do you agree with that?
Absolutely, Vikash. So we looked at our area under the curve for BPD diagnosis. First lung ultrasound is around zero point 0.8, which is similar for NaCHD validation studies. So there's again zero point 0.8. The one of the biggest advantages that so within 3 hours we should be able to diagnose to some extent. But the one small limitation, because as you and me know, is that we had very small number of babies in our study with BPD because our base population is
Mm.
up to 34 weeks. So we won't be able to conclude strongly. The future studies should include more premature babies, and then we should be able to validate our finding. If it shows that that yearly we can predict, that's better. So we can give the medications or interventions early on for certain babies rather than giving to all the babies universal treatment.
Or are you thinking better is to have there's a room for a study where you use first lung ultrasound scores and integrate it to various other factors like not having steroid, chorionitis, and see how you're predicting the BPD, severe or moderate BPD. So that might be another study
Yeah.
to think about.
Absolutely, Vikash. Again, so again, we could because even the current studies, whatever the literature is there, they are start predicting from day 7, day 10. By the time we may miss the window, um, even a study and the real clinical like meaningful value to the patients are going to be if you perform early lung ultrasound, the scores are higher, and you start a treatment. Are we going to reduce the severity of BPD at 36
Mm.
weeks? So same thing with the surfactant. If you give surfactant yearly, are you going to change the clinical course? That's the important clinical question, which deserves a randomized control trial.
No, thank you, Prakash. Virginie, do you have any comments on this?
Yeah, I think it's a really interesting point, and something, as you said, we were not expecting to have such a high prediction value of the first ultrasound to predict BPD, but I would be very cautious because we are the only study to show that, and it's something it needs to be confirmed with other studies. And the other thing, I don't think we will make any decision based only on lung ultrasound score, and there's lots of area of research in the heart, as you know, especially about the diastolic function. And I think the future will probably, yes, predicting earlier than 7 days, but also to include other clinical and cardiac parameter, because lung is not only airways, and we'll just look at airways here. It's vessels and all the clinical history before birth. All of that probably it needs to be taken into account. So I think if we want to make an earlier prediction, we'll have to include more clinical and vascular parameter.
Virginie, on a similar note, because again, as you said, it was a bit surprised when the findings was that the first lung ultrasound was better than the fourth lung ultrasound. And normally we were probably expecting that the fourth lung ultrasound would be more predictive of BPD. So do you have any explanation or any reasons why you think that?
No, I don't. But as you know, I'm looking into all these prediction we got wrong. That I try to understand, because all study says we have that good prediction with lung ultrasound, but we never look into why sometimes we have babies with a score of 12. We have babies with score of 12 who finally did not end up receiving surfactant, and we got quite a few in our studies. But these babies develop BPD. Okay, so I think it's interesting to see the pattern of this baby that didn't get surfactant despite high score, and this one developed BPD. So I think we need to go deeper into each case for that to give a good explanation. Yeah.
There are more questions coming in, so I'll jump to the next questions. We have got enough time for the questions. Prakash, one of the questions again comes from Ashraf is that we mentioned there was no intervention depending on the lung ultrasound images. What he's asking is, what if we found atelectasis, which is common in preterms? Did we not intervene? And did lung recruitment strategies depending on lung ultrasound?
No, we did not intervene because that's a study protocol, because that's not the standard of care. So lung ultrasound definitely in maybe Vikash's center maybe slightly more advanced in terms of using lung ultrasound for clinical use. When we started the study, when we performed the study, lung ultrasound was not the standard of care. Still, X-ray was used for understanding atelectasis, recruitment, and then based on that, they did intervention. So we did not perform any intervention because ethically we could not do that.
The only thing, Prakash, is there was one case where we identified pneumothorax, which Virgin is aware of. So in that case, we did confirm it with the X-ray to start with, but that's incidental finding, which is then required. Fortunately, baby did not need any intervention. All it needed was monitoring, actually, from that perspective. So, of course, we will find something here and there, but we stick to the study protocol of non-intervention.
Absolutely, yeah. So we also got two pneumothorax babies and part of that, but we could not. We excluded that from the study.
And regarding the recruitment, we have to be cautious because there's no recommendation today to do recruitment maneuver based on the lung ultrasound because we don't know the effect on the area that are well opened. We don't know the effect on the cardiac function. So we can do it, but just you to know, there's no recommendation by expert or any publication to do it routinely. Positioning, yes, but I think I would just bring a word of caution about any intervention on on recruitment based on lung ultrasound.
There are a few questions coming from Omaima, which are very interesting. So first, the question I'm going to take is about the TTN. So what Omaima is asking is, the problem TTN can easily score 8 or 9. And what she's asking is, if we follow the cutoff scores, then we would administer all TTN cases with surfactant if we follow that score as a pattern.
No, so it's other way around. Maybe I could have explained better the study methodology. So all the babies, we did not make any intervention based on the score. So when the baby comes, like 30-weeker baby comes to unit with CPAP, within 3 hours we did the lung ultrasound. That means the local operator, he will record all his scores and the clinical values and record the video clips. Whether they give surfactant or not is completely the clinical team. The clinical team will do current standard of care. For example, in our unit, the baby is on CPAP of 6 to 7 and around 30 to 40% oxygen. They'll do an X-ray and a gas based on all the parameters, workup breathing, X-ray finding, CO2 levels, and the amount of oxygen, amount of CPAP pressure. They'll take a call whether the baby needs surfactant or not. Then they'll go surfactant. So that information, I have it. The video clips are sent to Virginie, so she wouldn't have any clue about whether baby receives surfactant or not. And we retrospectively, all the scores done by Virginie is taken, and then we matched it with whether baby receives surfactant or not. And we try to find out what is the best score that can predict the need for surfactant. So our study is not interventional study, it's not a randomized study, it's just purely observational study. What is the best score that can predict lung ultrasound? Score for surfactant, what's the best score for predicting BPD, whether there's value of serial ultrasounds. Ours is observational study, not an interventional study.
Prakash, if I understand it right, so she might be not asking relevant to our study itself, but
Okay.
to mention that if we come with a cutoff of 8 or 9
Yeah.
for in babies to give surfactant, what she's suggesting is if a lot of TTN would have H score of 9, so then a lot of TTN babies will get surfactant unnecessarily.
Absolutely, I totally agree. The issue. So we need to understand the sensitivity. Sensitivity for our lung ultrasound score is around 80%. Predominantly, that's what all over the most literature would say. That means 20% of the diagnosis cannot be made, and 80% means sensitivity. That means there are going to be high false positive, right? So that's understandable. So as again Virginie mentioned, one of the point is that we never use one single investigation to make a diagnosis or make an intervention. It should be multifactorial.
That's true.
So I would use in my clinical practice, what I've changed, what I'm using now is that if a baby is on 25% oxygen and coming to unit, and I look at whether baby receives steroids, how optimization is done for the preterm delivery, how much CPAP I'm giving. I use lung ultrasound as a part of the equation, not only as if the baby's on room air and CO2 is like 5, baby's well steroided, baby's 31, 32 weeks. So I would still, the lung ultrasound score is bad. I will still wait, still sit tight. I would not give surfactant, and then maybe subsequently may repeat the lung ultrasound later. To answer your point, yes, I'll take it as one part of the decision making, not completely sole decision making based on lung ultrasound. To each of this has a limitation of sensitivity. That means there should be false positive, should be there, will be there.
No, thank you. Thank you, Prakash. Virginie, do you have anything else to add?
I totally agree with Prakash. I think it's very important where you are around the 8, 9, to repeat the ultrasound, to review your baby later, an hour or two after, and well positioning, and to repeat the score. I think that's crucial. And the second thing is the risk of giving too much surfactant. I think that was a very nice study published by Racchetti in Journal of Pediatrics. This is the Esther study, when they show that when you use the lung ultrasound score as an intervention, it was lung ultrasound score or a European recommendation, whichever comes first. They did not use more surfactant using a score of 9. So there was not more surfactant use when you implemented the lung ultrasound score in your surfactant administration decision.
Oh, thank you. Thank you, Virginie. I completely agree with both of you. We've got a very interesting question from Suresh. Was there any difference in the beginners and advanced, because we grouped them into 4 categories, beginners and advanced, doing ultrasound and picking up the findings? And would that have caused the bias?
Yeah. So thank you, Suresh. So again, as we pointed in one of the slides, the beginners and the group who are in the training group, they had more number of uninterpretable, poor quality video clips. As you know, so obviously the advanced people or intermediate groups, they had less number of uninterpretable video clips. That's the first answer. The second part of the question is that no, that will not cause bias because we did not use their scores for any analysis. The table, all the calculations was done based only on Virginie's score, that's the expert score. Is a blinded assessment without any kind of confirmation. So no bias is caused by various operators, but again, as you would expect, the beginners and the training people had more poor quality scans. And we do have some data about how the quality improved over the time. So we had regular meetings with all the investigators, Bikash, Mahmood, and Virginie. So we all learned through this research how we could improvise our quality of image. So that definitely improved over the period of time. So we had regular meetings which improved the quality of the video clips we captured.
No, thank you, Prakash. And again, one thing again, which probably we are looked into by looking into the journey of trainer. So people who are being trained to do lung ultrasound from not doing anything, just to attend the training course to be able to do better scan, faster scan. So we have already looked into that study too, which we would like to present at some other day or publish data. It's a very interesting finding. So Virginie, probably it might be a great experience from you reviewing about 300 and the 3,000 scans from 27 users. Would be very interesting for you to review them.
Yeah, no, that was a great experience, and to see the progress. I mean, what the satisfactory part of this is to see how many non-interpretable and poor quality was. And when we met, we gave feedback to each of the centers, isn't it? And you could see the quality and everything improving with time. So that, I think this is very encouraging for everyone. I mean, if you don't hesitate to start research, because research is a great way for everyone to get on board with this technique, and it's a good opportunity to learn. And yeah, that was initially a bit difficult with the quality, but I was so pleased to see all the progress done by all the teams. That was wonderful.
No, thank you so much, Virginie. Again, a similar question by Anna Milan, who's asking, can we look again at the results of the interpersonal variability? I think it's a main result of the study and very interesting. And then she asked also define the ROC for surfactant administration. She asked, did we standardize the clinical indication for surfactant administration in different centers? As far as she understood, the results of the lung ultrasound was not used to decide if surfactant was needed or not. So she believed the clinical assessment was used.
Absolutely. So I think, sorry, there is a few questions. I think yeah, so we, because you alluded, we did not use lung ultrasound scores for decision, only clinical. We were not very prescriptive exactly which unit, how, what they have to use it, but most units among the three units are kind of similar in their respiratory guidelines and guidelines for surfactant administration. It's based predominantly on NICE guidelines. Smaller babies, when they are on around 30% oxygen, decent amount of CPAP pressure with the blood gas CO2 showing mild respiratory acidosis, received surfactant. So so we do have, we don't, there's not a huge variations, but there is some amount of center variation, subject variation could have been there, but not exactly, we are not prescriptive. Does it answer Anna's first part of the question?
We won't be able to see. I don't know whether Anna, you want to type it in the Q&A. If you're still around, we won't be able to see Anna. But you want to
So
take the second part? Yes, she said
yeah.
super. Okay.
And also the agreement, interrate agreement is just there. So it's slightly lower than we anticipated, but we think that's reason because of more number of operators were very novice operators. So hence there's a bit of slightly less agreement. But even this is we think is reasonable because it's like a moderate to substantial. And again, as you could see, one of the graphs which charts, I'm just trying to see these. Yeah, this is extreme hard work from Virginie, where she calculated every single poor quality videos. As you could see, our center had slightly more number of uninterpretable videos because our centers predominantly we never had did any lung ultrasound before the study, before 2023. Then by the end of the study, like 11 12 people started doing lung ultrasound. So that's the reason why we had more uninterpretable, and that's one of the very good secondary benefit of doing a research is that now we got two pros for lung ultrasound, and at least we trained in the region around 10 to 11 people who can perform lung ultrasound.
Prakash, very interestingly, you mentioned, sorry, Virginie, I'm going to get
No, I
back.
think Anna raised a big question that I think it's really interesting is because the question we had initially, because all the studies were done and published where experts reviewed the scan, and we have a good correlation between the score and the prediction of surfactant. But now the question she's asking, and I really asked this question myself, can our study answer the question, would a beginner, intermediate, be able accurately, confidently to predict the needle surfactant based on there? So for that, I think we should do this correlation, calculate this area under the curve per each population. I'm not sure we will have very good results, and that's normal. But I think that's a very good question. Yes, technically, at the end of the study, we did this survey. They achieved good quality technically. There was a good quality of scans. But in terms of scoring, can they confidently predict surfactant when they've just been trained? I don't think so. But we have to, I think, better answer that question. I don't know what Anna thinks.
She's asking, was there a clear difference between the in training and beginners?
Yeah, the more, if you say the quality of images, video clips, more poor quality from the training people compared to beginners. So 49% of the poor quality images are contributed by the training group, and beginners was like 19%. So there are some differences. Yeah, definitely.
Yeah, Prakash, what I was saying, so trying to suggest was people who don't, most of the lung ultrasound people who were scanning were there because I can tell you from my centers, and it would be similar cohort with other centers too, it is not that they've never touched the probe. They were probably using the probe for head scans, most of them. So, and the lung ultrasound is a bit of different skills. So it takes some time to get used to the probe and zone. So you can see the issue with missing images or uninterpretable images because of the way the scene loops are stored. But the agreement is about 84%, which I thought was a very high. I was not expecting an agreement around 80% from the scorers with an expert, which I would have never imagined that agreement in any other scans like lines or head or even for uh, heart. Heart is no way. So this again gives me that reassurance that lung ultrasound is something which is more easier to pick up in comparison to other type of focus, and can be applied in practice more, which again for me is a very, very big take home. I don't know any other studies which has ever shown that actually, which will be reassuring for so many trainees who are there online today to know that it's a skill which you can pick up more quicker, and your agreement with the expert is around 80%, seems to be very, very high. What do you think, Prakash and Virginie?
Uh, yeah, so sorry. That is absolutely true because a simple example is myself and our team. Before we started the study, we had, so maybe I was the only one had some experience. I would classify myself as a beginner before I started the study. Um, then I went up to intermediate because I did most of the scans in our unit as a part of the research. So two of our nurse practitioners, they are confident at least to say, yeah, this is a good lung or not so good lung, and they are very confident to diagnose pneumothorax. So that is a big win for our unit. And I would say four of our grid trainees in the region learned lung ultrasound. So they learned lung ultrasound through part of research, and in a quick period of time, as you said, the trainees rotate only 6 months in our unit. So within 6 months, they are most of them from the training to beginner. They've gone up to one stage like beginner only. Hopefully, if they keep carrying on, they'll become intermediate and advanced category near soon. So as a living example, we, as you would know, the literature says you need to perform around 20 lung ultrasounds to at least to make a reasonable certain diagnosis. So your point is absolutely right. Lung ultrasound much more easier. There's a steep learning curve compared to being told echoes, heart scans needs more than 200 to perform. Totally agree. I'm happy to listen from Virginia as well.
No, I totally agree. Nothing much to add. The only thing more from experience of running courses is I can see that the one who get a steep learning curves and get there is the one who goes straight to take the probe after the course. If you have a course and you start scanning 3 months later, that's too late. It's really the people who are determined, motivated, self-motivated, take the probe straight after the course and never drop. I think the key point is the personal motivation, but the learning curve is very steep.
So we got few more questions because we finished the presentation in time. So we had very good discussion. So few more questions before we close the session. One of the question is from an anonymous attendee who asked, my question is, what was the median time for administration of surfactant in babies who had different modalities to diagnose? Example, ultrasound versus X-ray. And what was the FiO2 threshold rather than the ratios?
Yeah. So I don't think we can answer the first question because we never used lung ultrasound for making the diagnosis and the giving surfactant. We just used not only the X-ray, as you mentioned, most units use multifactorial. So clinical picture, a chest X-ray, FiO2 threshold, CO2 threshold. So I don't think we use lung ultrasound as for intervention. The second question, what was the second question? Because they asked about
So one
the
was the
FiO2 threshold.
FiO2
Yeah,
threshold.
we do have the FiO2 values, but I don't have in top of the mind. But I would say on average around 30%, if I can recollect, like 31, 32 is a median. And we do have the carbon dioxide values, CO2 values as well. So yeah, instead we thought we'll report this numbers, the SPO to FiO2 ratio rather than actual FiO2 only. But we do have the values of FiO2 when they got surfactant as well.
And again, in similar line, Umayma asks the question about whether we use oxygen index or oxygen saturation index.
So we used two of the commonly used parameters because most of the babies started on non-invasive respiratory support, where we used modified oxygenation index. As you can see, which has been validated from many European centers. And again, we used SpO2, FiO2, but we do have individual data of what's the pressure, what the FiO2, what the SpO2. But we thought it's one simplified parameter that could make you understand about all the things. Now, from the SpO2 FiO2 ratio, you can understand what the saturation, what amount of FiO2. The same here. So we do have all the data, but we don't have it in at this point of presentation.
No, thank you so much. And I think so finally, the last question again from Anna, which question and a comment would be, it would be very interesting to understand the minimum training level required to be confident with the lung ultrasound scoring.
So obviously Virginia, because they are more experts than me, they'll answer. And Bikash and is one of his trainee who's a consultant, Shavin. They conducted a survey before and after, like conducted after that. They've shown it's a self-reporting survey, but most of the team members after they participated in the research where they performed an average of 5 to 10 lung ultrasound, they were confident in making RDS diagnosis. Pretty comfortable. 100% of them, they said they can diagnose RDS comfortably. The next comes the normal lung, they can diagnose pretty comfortably. The least was about TTN, and the next after this pneumothorax. Again, if time permits, maybe we will see the how do you define competency, how do you define their achieved competencies. I'm not certain, but again, I'll leave it to Virginia and Bikash to discuss that point.
Over to you, Virginie.
Because no, I have. I think again, to come back to Anna's point, I think the best way to answer that question is to look at the area under the curve, with the correlation between the score given by different level of experience people and the administration of surfactant. But as Prakash showed, we don't have enough number of people who score in the higher level of expertise. But I think that would be a nice study to see the prediction based on the level of experience.
No, I completely agree with that. On a similar level, I think so there is an opportunity and probably a secondary outcome of a study is to interrogate the learning experience of the person who are doing the study. So again, a similar question from Akoelisa, who asks, how many senior medical staff do we have on call out of hours in our unit to enable lung ultrasound within 3 hours? And how long does it take for you to obtain the 6 zones? So again, I think so we looked into that too.
Yeah. So again, as you could see, there is 16 trainees. Like majority of trainees are tier 2, like registrars, and many of them are nearly grid or very senior trainees. And 9 consultants performed, and 2 nurse practitioners, both of them quite senior as well. So again, the availability of the staff is a problem. So that is one of the reasons where we could not recruit. If you see this one. In our center, for example, no trained person available is 23, and not informed the study unit is around 22. So pretty much we missed a lot of babies because of that, because of the issue. But as the time progressed, we trained more people, and then that number reduced. And again, as Bikash Virginie said, it's very easy to train, and you can reasonably achieve competencies. And as long as we know our limitation, do not use lung ultrasound just purely as one modality to make your decision making. Take the whole picture, and then that should be safe. So yeah, definitely that's one of the reasons why we missed a lot of babies which could have been potentially recruited.
At the time, I think it's true that initially it takes time. It takes maybe 5-6 minutes to get those properly, and so it's a team. I think it's a team objective. It needs to be embraced by the whole team, not just by a few people, because the nurse needs to be involved. I mean, when nurse understand what you're doing, and they are really keen to help, to support you, and that significantly reduce the timing of scanning and improve the comfort of the baby. So I think if it's a team objective, some people say, I will never scan, but I will ask people who know to scan, and I will ask them to do it. Some say, I want to scan. I mean, all together, and if you have more support from the team, you will see, and the survey that Shavin Shelem did showed really well the decrease of the time duration of scanning during the whole protocol.
No, I completely agree, Virginie. And I think so you will have to prepare. Sorry, Prakash, I cut you off. I'll just finish this part.
Yeah,
is I mean, scanning hearts, particularly for many, many years, which can take time. So I think so, and that's what I teach trainees is to spend minimum time with your probe on the baby's chest. Is first of all is to acquire your, so once you have a machine setting, so from putting the probe, when you're putting, the whole idea is to, at that stage, is to take images and store your pictures as soon as possible, and then come back, close the incubator door, and then review the pictures later on and do all your measurements later on. So that's, and I think so that comes with time when people start their learning curve. But in the mind, the people should be aware of, to get this scanning, there should always be in the top of the mind, how can I do to minimize my scanning time on the baby? Just like in a cardiothoracic surgeons, the target is to decrease the amount of time it takes to do surgery on an open bypass. Same thing, I think so for our preterm babies particularly, it would be always useful that we spend as minimum time as possible while acquiring the images and more time on interpreting and reviewing those pictures.
Yeah. So again, Shavin and Bikash, they will be presenting at some stage the survey, self-reporting survey. Many of the operators, when they started the journey, they took average of around 10 to 15 minutes. By the end of the study, they reported around 5 minutes. 5 minutes for to perform each lung ultrasound. Again, we have shown that there's no need to change the position of the baby. So that means if the baby default position, if you do only front, it should not take more than around 5 minutes, I would think so.
No, thank you. I completely agree with that. So we will call it to an end. Thank you so much, Prakash, for your presentation. Thank you, Virginie, so much for giving your time and acting as a panelist. And thank you, Sadaf, for having us and organizing the whole webinar.
Yeah, thank you, Sadaf, and thank you, NeoFOCUS team for giving this opportunity to present our work. And obviously, thanks to Virginie, Bikash, Mahmood, and all the co-investigators to teach me lung ultrasound and complete this study. Thank you, guys.
Thank you, Prakash. Thank you, Bikash. Thank you, Sadaf, and the whole NeoFOCUS-UK education group. Wonderful organization.
Thank you so much, everybody. And don't forget to complete your feedback forms and you'll get your certificates after that.
Thank you.
Thank you. Bye.
Bye.